Hello, everyone. Matthew Adams again, Ducey, here to continue our clinical didactic training on clinical capnography. Okay. So we're just going to get right into clinical capnography. When you think of capnography, typically we think of a ventilation vital sign or an airway management tool. We've heard the term shark fin, endotracheal tube conformation, and so forth, but we shouldn't minimize those, but capnography is going to go a lot further than that. Okay, it can alert us to perfusion and metabolic problems. Yes, it's a device that we place in the airway as a measuring tool, but it's going to measure a byproduct that goes a lot deeper than that. Okay, end-tidal CO2 is a continuous variable. It's determined by basic metabolic rate, cardiac output is common, and of course ventilation. What we need to understand is that abnormal levels may reflect derangement not only in just ventilation, but in perfusion, metabolism, and of course gas exchange. We need to remember that respiration, ventilation, and oxygenation are very different concepts. They're not synonymous with one another, and we'll discuss that. Capnography, it's non-invasive, a good monitoring technique that allows fast and reliable insight into ventilation. Of course, patient's circulatory cardiac output status because of the pulmonary artery, and of course, metabolism, and we'll discuss and break that down as we go forward. Remember now, with carbon dioxide, the metabolic byproduct that it's reading, it's produced that by all living cells, it's diffused into the bloodstream, it's transported to the lungs, then perfused into the alveoli, and then exhaled through the airway. Okay? So what are we going to do here? I'm going to give you a little bit of a scenario here. We respond to a 56-year-old female complaining of shortness of breath. She has palpitations. After assessment and appropriate interventions, our vital signs indicate a blood pressure of 70/30. Our heart rate is 220, okay? And a respiratory rate of 40. You place the patient on the cardiac monitor, and this is the presenting rhythm, okay? That gives us the uh-oh factor, right? It's creating this sense of urgency. At least it does in me, right? I'm sure it does for you as well. So you may say, what does this have to do with capnography? Well, we're going to talk about that. Let's do a little parallel scenario here. We have a 16-year-old male with a history of asthma. She's complaining of shortness of breath, post-physical education activity while at school, and you perform an assessment, and these are your findings, okay? All right, so just as an EKG is a window to the patient's cardiac status, this was the point that I was driving home, capnography is the window to the patient's ventilatory status and can go much deeper, okay? Here in the specific situation, when we saw the VTAC in the other patient and those critical vital signs, we see a shark fin type of appearance in a waveform on capnography, which should give us that same uh-oh factor and sense of urgency, okay? So as we continue on with that specific scenario on asthma, what we suspect, history of it, okay, we're starting to see it, the frequency of the waveform change, but the appearance does not. Now we start to see an increase in end-tidal CO2 and a decrease in respiratory rate, okay? That is a critical clinical hallmark criteria of an asthmatic patient that is impending respiratory failure if we don't act quickly, okay? And we're going to talk about that and a whole lot more on this specific presentation. So let's get into our objectives here. We're going to define and describe end-tidal CO2, okay? We're going to differentiate between oxygen and ventilation, as mentioned. Define clinical indications for end-tidal CO2 in acute care. Capnography as a device to monitor ventilation during procedural sedation, transport, and CPR. We're going to review various technologies for monitoring, just as a quick introductory aspect to that if you've not heard it before. And of course, we're going to discuss the PaCO2 to the end-tidal CO2 gradient and its clinical application. There's some similarities and some assessments we can make in determining lung problem and poor oxygenation and ventilation. And of course, reviewing the clinical utility of capnograms, of course, we're going to identify a normal capnogram and interpret abnormal capnograms and their clinical interventions as well. So you want to remember that a history of capnography and EMS, it was initially used for monitoring anesthesied patients in the OR. So now there's new technology available for a time for EMS in both intubated and the non-intubated patients as well. So you remember that capnography provides the only continuous visual monitoring of ventilation, okay? So capnography, what is it and who's it used for? It's monitoring the concentrations of partial pressure of carbon dioxide, okay, in the respiratory gas. It's usually it's usually presented as a graph of expiratory CO2, which is measured in millimeters of mercury. It's plotted against time, but more commonly expired volume, okay. The plot may also show inspired CO2, which is an interest when rebreathing systems are being used or if the patient's rebreathing CO2. And we'll talk about that. A rebreathing system would be beneficial for a patient such who may be hyperventilating and then when they have maybe a traumatic brain injury. And we can use a specific ventilatory circuit for that where they have that second port so they can rebreathe that CO2. Also, capnography, we want to use it to its full potential with every patient with an altered level of mental status and deficiency in the ABCs in assessment, okay? So, give a little definitions and terminology here. So, capnos means from the fire of life, okay? It's the metabolism, okay? Remember that metabolism produces carbon dioxide as a waste product, all right? So what does capnography do? All right, well, capnography is going to provide information about CO2 production, which is our pulmonary lung perfusion, alveolar ventilation, which is our respiratory patterns, and of course, the elimination of carbon dioxide. So the shape of the curve is affected by some forms of lung disease. In general, there are obstructive conditions such as bronchitis, emphysema, asthma, any type of reactive airway disease in which the mixing of gases is within the lung is affected, okay? Now, conditions such as a pulmonary embolism and congenital heart disease, which affect perfusion of the lung, not necessarily the shape of the curve, okay? So we may see a decrease in the actual end-tidal CO2 metric value. So it actually greatly reflects the relationship between the two and arterial blood because of the pulmonary artery. So, and of course, it also is going to measure metabolism. Increased CO2 production is seen during shivering and fever. Reduced production in end-tidal CO2 is seen during anesthesia and possibly hypothermia. Okay, so the technology, it's a graphic display of instantaneous carbon dioxide concentration, okay, versus time or expired volume during a respiratory cycle, all right? So capnographs usually work on the principle that CO2 absorbs infrared radiation. A beam of infrared light is passed across the gas sample to fall on a sensor. So the presence of CO2 in the gas leads to a reduction in the amount of light falling on the sensor, which changes the voltage in the circuit, which is what gives us our metric readings, okay? So the capnometry, as we were discussing, the measurement and display of carbon dioxide on a digital or analog monitor. It's maximum inspiratory and expiratory concentrations during a respiratory cycle. Okay, the drawback to it is there's no waveform. Okay, basically without a waveform, it would equate to having a heart rate without an EKG. All right, it can change over time. Simply put, you want to have that waveform there with you. Okay. Colorimetric devices, really a dinosaur type approach. Old hat, maybe used as some backups in some places. In colorimetric capnography, it's a filter attached to an endotracheal tube which changes the color from purple to yellow when it detects carbon dioxide. It does have several drawbacks compared to waveform capnography. It's not continuous, has no waveform, obviously. There's no numbers, no alarms, can be easily contaminated, hard to read in certain logistical situations such as dark environments, and can give false reads. course, 6 breaths will have to be developed before a determination can be made. Now, with capnography, mainstream and side stream. Okay, let's talk about those just a bit in more detail. With mainstream, it uses an infrared CO2 sensor connected directly to the airway between the endotracheal tube and the breathing circuit. Typically is what you're going to see in the life packs, like a life pack 12, life pack 15, and typically is what's currently being used. Okay. Now, on the other hand, with side stream, airway gases are collected from the breathing circuit, and the infrared sensor is located in a remote monitor. So the drawbacks to that would be it requires 150 to 200 milliliters of air to measure a CO2 level, and it requires frequent calibration. There's frequent occlusion of tubing by moisture and secretions, and a lot of times it's inaccurate in neonates, infants, and young children. So obtaining a respiratory rate, okay? Using capnography is not just for CPR anymore, okay? The benefits of capnography monitoring stretch far beyond advanced airway management and monitoring cardiac output. At a very basic level, the use of capnography can provide an accurate respiratory rate in a matter of seconds, okay? And it can supplement the traditional manual count for 30 to 60 seconds when we're doing a respiratory assessment. So, obviously obtaining an accurate respiratory rate in a chaotic field setting can be challenging, and recorded respiratory rates can typically be often inaccurate. So this is all in real time and always typically correct, okay? So it accurately measures rate, as I mentioned, okay? It's for both the intubated and non-intubated. It's continuous breath-to-breath monitoring. Again, as I mentioned earlier, it equates to the EKG monitoring in a cardiac patient. And it can allow the clinician to quickly recognize apnea and obstructive apnea as well, okay? Now, as I mentioned, I do want to talk about and differentiate between oxygenation and ventilation. They do not mean the same thing, okay? Now, oxygenation is how we get simply oxygen to the tissue. Oxygen is inhaled into the lungs where gas exchange occurs at the capillary alveolar membrane. Oxygen is transported to the tissues through the bloodstream, and then the pulse oximetry is what's going to measure this. At the cellular level, though, oxygen and glucose produce combined energy, okay? Carbon dioxide, a waste product of this process, also known as the Krebs cycle, diffuses into the blood. Now, ventilation, okay, on the other hand, it's simply the mechanics of the movement of air. It's how we get rid of carbon dioxide. Carbon dioxide is carried back through the blood and exhaled by the lungs through the alveoli. The capnography is measuring the ventilation aspect of this process, okay? Now, when we're looking at capnography, you want to remember that capnography provides an immediate picture of the patient's condition, okay? It's measuring cardiac output, metabolic processes, perfusion, and so forth. With pulse oximetry, it's a good assessment tool, and we need to use it, but it's typically a delayed process. Now, well, that can be proven by simply putting a pulse oximeter off a cardiac monitor on your finger, holding your breath, and see it continuing to show a good reading, possibly for up to a minute or so of an adequate, maybe 97% when you're not even breathing, okay? But if I stop breathing with end-tidal CO2 and waveform capnography, it immediately stops. So again, a better picture of the patient's clinical status, okay? Now, let's talk about its physiological functions. We're going to get into more depth here. While it's a direct measurement of ventilation, as we've been talking about, again, it's a measurement of metabolism and circulation. So as I mentioned, an increase in metabolism will increase the production of carbon dioxide, which will increase the end-tidal CO2. A decrease in cardiac output will lower the delivery of carbon dioxide into the lungs, which is going to decrease the end-tidal CO2. So when it monitors changes in ventilation as a movement of air, asthma, COPD, airway edema, foreign body, and so forth. But with diffusion, it's going to help us to monitor diffusion, okay? Spontaneous, diffusion is the spontaneous movement of gases without energy or effort of the body. It's the gas that's in the alveoli and the blood in the capillaries in the lungs, okay? We may see this being monitored in patients' conditions such as pulmonary edema, alveolar damage, carbon monoxide poisoning, or smoke inhalation. With perfusion, perfusion is simply the process of the cardiovascular system pumping blood through the lungs. Okay, and keep it that simple. We can see insults in this with shock, pulmonary embolus again, cardiac arrest, or even severe dysrhythmias. Okay. Now, with respiration, tie those two into that. Okay, all three components of respiration, as I mentioned, metabolism, transport, and ventilation, are all involved in the appearance of carbon dioxide in exhaled gas. So the summation to all of that is that capnography is going to give us an excellent picture of the respiratory process. Okay. Now let's get on another note here: the arterial and end-tidal seal values. Okay. The PaCO2, which is the partial pressure of carbon dioxide in arterial blood, okay? The PaCO2 is measuring by drawing an ABG, which measures the arterial pH, okay? It's the partial pressure that's in the alveoli. The end-tidal CO2, or sometimes referred to as I got the P in parentheses, the PETCO, it's the maximum partial pressure of CO2 at the end of the breath, what we all know and love, okay? It's if ventilation and perfusion are stable, the two variables will correlate with one another. Okay, they should match within a few millimeters of mercury. Okay, well, we're going to talk about the gradient now. The gradient is the difference between the arterial carbon dioxide pressure, the PaCO2, and the end-tidal CO2. Okay, it's a result of the relationship between ventilation, the abbreviation V, okay, and which is airflow to the alveoli, and perfusion, you may see abbreviated as Q, which is the blood flow to the pulmonary capillaries. Now, of course, calculating the gradient requires obtaining a simultaneous arterial blood gas sample and an end-tidal CO2 measurement. But in normal healthy lungs, there's a good match of alveolar ventilation and perfusion to the pulmonary capillaries, which is going to result in the end-tidal CO2 closely correlating with the partial pressure of carbon dioxide. So in that said, therefore, the PaCO2 may be estimated by actual end-tidal CO2 measurements in patients without significant cardiopulmonary disorders, which is a great assessment tool for us. You know, the research has shown that patients in normal lung function, that the normal gradient is 2 to 5 millimeters of mercury. But with lower and upper and lower airway diseases, seizures, metabolic problems such as DKA, the gradient is going to increase due to a VQ, or ventilation to perfusion mismatch, okay? Now, let's talk about that VQ. In normal respiratory physiology, the ventilation perfusion ratio is a measurement used to assess the efficiency and adequacy of the matching two variables. V for ventilation, the air that reaches the alveoli; Q, perfusion, the blood that reaches the alveoli, as I mentioned, okay? Now, in shock perfusion, okay, a low VQ in diseased or unhealthy lungs, or in cases of impaired cardiac function, okay, there is ventilation mismatching, VQ mismatching, that causes the gradient to increase or widen. You know, if ventilation or perfusion are unstable, a VQ mismatch will occur. This can alter the correlation between the two variables, the PaCO2 and the end-tidal CO2. So an increased gradient can occur due to varying degrees with increased dead space ventilation, shock perfusion, as we have here, and other causes, okay? As we see in the picture, there's no exchange of the O2 or CO2 to the alveoli. So that's my drawing of an alveoli disease there. So the areas of the lung are being perfused, but they're not being ventilated, in other words. So with shock perfusion continued, it can mismatch due to caused by blunt shunting, such as may occur during atelectasis, you know, where we're perfusing an unventilated lung area, or by dead space in the lungs, ventilating unperfused lung area, such as occurs with a pulmonary embolism or even hypovolemia. So in short, anything that's causing the alveoli to collapse or isn't alveolar filling. Okay. Now, regardless of the reason, abnormal increases in the gradient greater than 2 to 5 millimeters of mercury is an indication that CO2 removal by ventilation is not keeping up with the CO2 production by metabolism. Let me say that again. Regardless of the increases, okay, regardless of the abnormal gradient, it's an indication that the CO2 removal by ventilation is not keeping up with the CO2 production by metabolism, okay? So in dead space ventilation is the volume of air which is inhaled that does not take part in the gas exchange, either because, one, it's in the conducting airways, or two, reaches the alveoli that are not perfused or poorly perfused. In other words, not all the air in each breath is available for exchange of oxygen and carbon dioxide. Okay? In dead space, the gradient is large and ventilation is not the problem, but perfusion is the problem because no exchange of oxygen or CO2 is taking place. So areas of the lung may be well ventilated, but not perfused. This may happen in conditions that cause a significant drop in pulmonary blood flow, such as a pulmonary embolism or a decreased cardiac output. Now, why is this understanding alveolar dead space important? Remember that alveolar dead space is the sum of volumes of those alveoli which have little or no blood flowing through their adjacent pulmonary capillaries. The alveoli are ventilated but not perfused, where as a result, no gas exchange can occur. So why does an increased alveolar dead space create a gradient? Well, alveoli that do not take part in gas exchange will still have no carbon dioxide. Therefore, they will dilute the CO2 from the alveoli that were perfused. So the result will be a widened end-tidal CO2 to PaCO2 gradient, okay? All right. Now, dead space ventilation. Again, this is more in terms of our monitoring respiratory as well. Dead space is the volume of a breath that does not participate in gas exchange. It's ventilation without perfusion. In short, anything that causes a significant drop in blood flow, such as these diseases listed, or even using a positive end expiratory pressure beyond the optimal levels. Okay. Now, let's break down the capnogram so we can start tying everything in together here. Okay, this is the typical illustration of what a capnogram should look like. The expiration phase is on the left, and the inspiration phase is on the right. Okay, the capnogram is a direct monitor of inhaled and exhaled concentration, or the partial pressure of CO2, right? And an indirect monitor of the CO2 in arterial blood gas. Okay, so the CO2 waveform can be analyzed for specific characteristics. The height shows the amount of CO2. You have the frequency, your rhythm, your baseline, your shape, and of course your length will depict the time. Okay. Now let's break it down even further, understanding the waveform and the processes there. So looking in this illustration, A to B is post-inspiration dead space. It's post-inspiration dead space exhalation as a clearing of the anatomic dead space. There's no gas exchange taking place here. B is the start of alveolar exhalation, whereas BC is the exhalation upstroke, where dead space gases are now mixing with lung gas, which results in the rise of the end-tidal CO2. Then, of course, the CD phase is the continuation of exhalation, or the plateau, okay, as all the gas is in the alveoli now, okay, rich in CO2. CO2 is evolving from the alveoli. And then D is the end-tidal value. All right, the peak concentration, the end-tidal CO2, as we all heard, okay? And then the DE is the inspiratory washout, okay? Now, the height and slope of the alveolar plateau, the CD component, is dependent on the CO2 content of the alveoli, okay? The CO2 content is in turn dependent on the ventilation perfusion ratio of the alveoli. High ventilation perfusion alveoli contain relatively low partial pressures of CO2, while low ventilation perfusion alveoli contain really high partial pressures of CO2. So in other words, it can be concluded that the height and slope of the alveolar plateau is dependent on ventilation, cardiac output, and more importantly on the VQ relationship. It can also determine and mean that there may be an even distribution of the exhalation of CO2, which would give it that shark fin shape in reactive airway diseases. Okay. All right. So reviewing the waveforms. Okay, we've got a list here, bronchial spasm and so forth. So we must consider more than one cause for abnormality. Is it a ventilation versus perfusion? Is it hypoperfusion versus hyperventilation? Is it air trapping? Is it dead space? Is it a machine problem? Is it a patient problem? Of course, we'll want to roll out excessive respiratory rate and tidal volume. You know, we're going to let our experiences be our guide to identify high or low in tidal CO2s. We'll put that in the context of our patient's circulatory and metabolic picture as well. Okay. Now, bronchial spasms here, or alveolar sloping, as I was just mentioning, the end-tidal CO2 monitoring on a non-intubated patient is an excellent way to assess the severity of the asthma or COPD or any airway reactive disease and the effectiveness of your treatment. You know, bronchial spasms will produce that characteristic shark fin waveform as the patient has to struggle to exhale, creating that B to C upslope. Okay, the shape is caused by uneven alveolar emptying. You know, multiple studies have confirmed the sloping shape correlates to bronchial spasms and obstructive lung disease. You know, asthma value changes with severity. So with a mild asthma, the CO2 will drop below 35 as the patient begins to hyperventilate to compensate. And as the patient worsens, as we saw in that scenario in the beginning of this presentation, the CO2 levels will rise to normal, which is not a normal finding, by the way. And when the asthma becomes severe and the patient is tiring and has little air movement, the CO2 numbers will rise to dangerous levels above 55, 60 millimeters of mercury, okay? Definitely approaching, if not already there, respiratory failure. Even if they're conscious and they're in those numbers, they're respiratory failure. You know, successful treatment will lessen or eliminate the shark fin and return that end-tidal CO2 to its normal range and normal appearance, all right? All right. So here, in that decreased muscle relax effect here, the patient is breathing against the ventilator or some other positive pressure device such as your BVM, okay? The cleft in the far right portion of the alveolar plateau indicates the diaphragm is moving and causing a entrainment of fresh air. So a cleft can occur in any part of the alveolar plateau when that patient attempts to breathe against the ventilator. That's simply what this is going on here. They're breathing against a ventilator. That muscle relaxation is no longer affecting. So, and then of course the cleft that we see is called the Curare cleft. It may not be present in every waveform. So in a flatline waveform for the non-intubated patient, if CO2 gas is completely or partially obstructed, the slope of the ascending limb of the capnogram has little or no alveolar plateau. Now with the intubated patient, of course, we want to look for a kinked or occluded airway, or maybe due to reactive airway disease such as COPD or secretions from it, or maybe even a foreign body in the airway, okay? So with a flatline waveform with a sudden drop to zero, okay? Of course, on a non-intubated patient, apnea, I mean, simply put, total airway obstruction may be also present, or very shallow respirations with no gas exchange, or maybe equipment problems too. But with a sudden drop from zero on an intubation patient, maybe a kinked ET tube, or maybe also defective equipment, or a total disconnection, or a ventilator device where the patient also has stopped breathing. So looking on the right-hand side of this slide of the picture on the right with only small, short-lived capnograms taking place, and the CO2 becomes immeasurable, more than likely this is esophageal intubation, okay? So this does not mean you are good to go. You know, ET tube esophagus, ET tube placement in the esophagus may be briefly detected, you know, may be briefly detecting CO2 following a carbonated beverage ingestion when gastric distension was produced by mouth. The mouth ventilation, God forbid anybody still does that. Residual CO2 will be washed out, though, after 6 positive breaths. With hypoventilation, our primary goal is to prevent hypoxia by early identification of hypoventilation. So when a person hypoventilates, their CO2 is going to go up because they're blowing, or excuse me, they're retaining. So a hypoventilation can be caused by an altered mental status, such as an overdose, too much sedation, intoxication, a postictal state, maybe a head trauma issue, a stroke, or even a tiring CHF patient. Other reasons CO2 may be high is increased cardiac output with increased breathing, fever, sepsis, pain, severe difficulty breathing, depressed respiration, or even chronic hypercapnia. Some diseases may cause the CO2 to go down, then up, then down, then up, such as what we would see in a patient with asthma. Okay. With hyperventilation, when a person hyperventilates, their CO2 is going to go down, right? So hyperventilation can be caused by many factors, from anxiety to bronchial spasms to pulmonary embolism. So other reasons CO2 may be low could be cardiac arrest, decreased cardiac output, hypotension, hypothermia, or severe pulmonary edema. You know, one thing we want to remember is that ventilation equals tidal volume times the respiratory rate. So a patient taking in a large tidal volume can still hyperventilate with a normal respiratory rate, just as a person with a small tidal volume can hypoventilate with a normal respiratory rate. So that said, you'd want to look at abnormal respiratory patterns, such as Shane Stokes, where they have deeper breathing followed by decreased breathing to sometimes apnea, or your Kussmaul's, where they have deep and labored breathing, maybe due to DKA or possibly renal failure. Now, CO2 rebreathing. If the patient is rebreathing previously exhaled CO2, the end-tidal CO2 value is going to increase, and the baseline is what we would see is elevate, as you see in the picture there. So the waveform will not return to zero at the end of its inspiration. So rebreathing, so that rebreathing aspect producing gradual elevation of the baseline and end-tidal CO2. And that's going to be caused by a malfunctioning inspiratory valve on the ventilator. Other causes could be incomplete inhalation or exhalation. The CO2 is not getting completely washed out on inhalation, or there's air trapping or rebreathing CO2 from a vent circuit problem as well. Okay. With endotracheal tube leaks, if air leaks around the endotracheal tube cuff, the alveolar CO2 gas is diluted and it's going to blend with the downstroke of the capnogram, as we see in this illustration. So basically what would be indicated here is a deflated or leaky tracheal tube cuff, or maybe possibly even an artificial airway that may be too small for the patient. With the head injured patient, the carbon dioxide is going to dilate the cerebral blood vessels, so which is going to increase the volume of blood in the intracranial vault and thereby increase the ICP, right? So we'd be recognizing the head injured patient and titrating. I didn't say hyperventilating, I said titrating their CO2 levels to the 30 to 35 range, and can help relieve those untoward effects of ICP. Remember that titration is not hyperventilation, okay? Intubating a head injured patient and using capnography gives a means to closely monitor CO2 levels. Now let's talk about metabolic derangements here. Okay, we can even use this end-tidal CO2 to help assess sepsis. So end-tidal CO2 levels correlate with elevated lactose levels. Yes, it's true, which can predict mortality in patients with suspected sepsis. So if oxygen isn't readily available to body cells, anaerobic metabolism is going to occur with lactic acid as a byproduct. So that serum lactate is what's going to measure that. It's going to indicate low tissue perfusion, or in other words, hypoxia. So early identification of sepsis is the best opportunity that patient's going to have for aggressive therapy to improve survival, right? So end-tidal CO2 can be utilized as a pre-hospital screening tool or intrafacility transport. Now remember, most of these screening tools rely on point-of-care testing, suspicion of the infection such as the systemic inflammatory response syndrome criteria, point-of-care serum lactate levels, but it is possible to screen for severe sepsis without depending on these costly devices and time-consuming blood draws if they're not readily available to you. Severe sepsis is characterized by poor perfusion, okay, leading to a buildup of serum lactate, resulting in metabolic acidosis. So end-tidal CO2 levels decline in the setting of both poor perfusion and metabolic acidosis. So to compensate for metabolic acidosis, patients increase their minute ventilation, right? So this increased respiratory rate blows off carbon dioxide and lowers the end-tidal CO2. At the same time, poor tissue perfusion decreases the amount of blood flow to the alveolar lungs, reducing the amount of carbon dioxide that can be exhaled. The most dramatic demonstration of this process is during cardiac arrest. So that said, therefore, end-tidal CO2 is inversely proportional to lactate. As lactate levels rise in septic patients, end-tidal CO2 levels are going to drop. Very interesting factoid of information concerning sepsis. Okay. So identification of patients in DKA. Now remember, simply put, CO2 is the smoke of metabolism, right? More specifically, CO2 is created after the acidic byproducts of metabolism are buffered by bicarbonate. Because CO2 is a byproduct of metabolism, anything affecting the metabolic rate affects the CO2 production and consequently corresponding end-tidal CO2 levels, okay? Metabolic pathways must be supplied with essential nutrients such as sugar, water, oxygen for a normal metabolic rate to occur. So if perfusion is compromised, so is the delivery of these components necessary for metabolism. So the result is going to be a decreased metabolic rate, which is going to decrease the CO2 production. Or if a patient is in metabolic acidosis, which is clinically defined as an acidic pH with depleted bicarbonate, less CO2 will be created, which is going to lower the CO2 levels, okay? So in the human body, remember that bicarbonate levels are strictly regulated by the kidneys and are slow to respond to the pH changes. You can have all the acid you want building up in the system, but without a proportional increase in bicarbonate available for buffering, you won't see the increase in CO2 production. So with all that said though, although it's a diagnostic tool, capnography isn't specific, okay? Capnography provides a reliable and accurate end-tidal CO2 level, but there's no printout or voice, obviously, from the machine that's going to cause you and tell you what the problem is, okay? Underlying causes must be identified, and diving into your patient's clinical picture and coupling capnography measurements with your other traditional assessments can be a very huge benefit for us as clinicians. So if a patient's hyperglycemic without an excessive respiratory rate, there's no Kussmaul's, which remember Kussmaul's is a late sign, assess their end-tidal CO2. If their end-tidal CO2 is greater than 30, they probably still have adequate bicarbonate. If their end-tidal CO2 is less than 30, the bicarb is now becoming depleted and would expect their blood gases to show metabolic acidosis. So without capnography, we often assume that the patients are in DKA if they have a high blood sugar. And again, Kussmaul's would be another obvious sign, but patients can be in DKA for a long period of time prior to the onset of Kussmaul's, okay? And going back to what we all know what capnography does, monitoring the effectiveness of chest compressions. It monitors the end-tidal CO2 levels, measures the cardiac output, right? It's a good way to measure the effectiveness of CPR because of the pulmonary artery and the return of blood flow. So it can detect the presence of blood flow, even in the absence of major pulses. It can also rapidly indicate changes in pulmonary blood flow, cardiac output, right? Caused by alterations in the cardiac rhythm. So it correlates well with coronary perfusion pressure and cerebral perfusion pressure. That's why they tell us to push hard, push fast, allow for complete recoil. Okay, properly done, chest compressions can provide 25 to 30% of normal blood supply to the brain. Okay, adequate chest compressions promote the elimination of metabolic waste. That's why they went from ABCs to CAB in the BLS component. So for a given ventilation zone, the end-tidal CO2 is a function of cardiac output. It's pulmonary perfusion. Okay, it's objective data for a decision to be made to cease resuscitation. Okay, these are some certain trends that we can look at. So an abrupt increase in end-tidal CO2 may indicate a return of spontaneous circulation, right? So an increase in pulmonary circulation brings more carbon dioxide into the lungs for elimination. So we would confirm that with an EKG and capnography. If they have a questionable pulse, we can't feel the pulse, okay, I can see an end-tidal CO2 reason. One reason why it may be hard to palpate is that there's still arterial vasoconstriction taking place, which may make that pulse difficult to detect. So monitor and look at the waveform capnography. Its present likelihood is that you have a return of spontaneous circulation, specifically if it's sustainable. And put your stethoscope on the chest. You know, if there is heart tones, volumes generate sounds due to the opening and closure of the valves. So you'll be able to hear, hopefully, heart tones as well. All right. Let's give a case scenario here. This is going to be similar to a couple of ones we did on the initial. Okay, the patient is a 65-year-old male complaining of crushing substernal chest pain. He rates the pain as a 10 on the scale of 1 to 10. He denies shortness of breath or any other complaints. He has a history of cardiac disease and asthma. Vital signs 130/80. Heart rate is 100. Respiratory rate is 20. And the SpO2 is 96, and the end-tidal CO2 is 40. Cardiac monitor shows sinus tach, and his capnograms are on the following picture there below. Okay, so let me back up there. What would be our concerns here? Kind of think this through. Really, the complaining of complaints there would be our major concern. It looks like he's perfusing well, looks like he's got good ventilatory, respiratory status, and so forth. So this ventilatory aspect and perfusion aspect and metabolic aspect is the proof of point that this can show good relationships, even with patients complaining of some sort of cardiovascular issue such as this here, okay? Now, case 2, patient is a 25-year-old male, history of asthma, okay? He's been compliant with his medications until he ran out of albuterol. Today, while at a basketball game, he gets short of breath. He does not have his albuterol inhaler with him. He presents sitting in the bleachers in minor respiratory stress. It's noisy and hard to hear the lung sounds. This is where end-tidal CO2 and waveform capnography would come into play. And looking at this specific waveform, okay, it's not normal. The end-tidal CO2 is not normal, and we ought to be very aggressive in taking care of this patient here, okay? Let me give you another one here. An observer called in 911, 76-year-old male sleeping and unresponsive, had a gash on his head, known history of hypertension, ETH intoxication, heart rate of 100, blood pressure 188/82, respiratory rate's 10, and SpO2 is 96 on room air, okay? The end-tidal CO2 is above 50 millimeters of mercury, has a box-shaped waveform, okay? So how does low end-tidal CO2 affect ICP? Does it increase it or decrease it? It's going to increase it because of the higher the end-tidal CO2, the greater of a concern in ICP in a patient with a closed head injury due to the vascular changes in the vessels, right? Okay, so what would we do with rate? Okay, we would want to slightly titrate that rate between depending on where we get the end-tidal CO2 to be, so we may have to increase that rate just a little bit to drop the CO2 to blow it off, okay? All right. Any questions you may have, please feel free to email me. Thank you for watching the video. Please proceed with the exam to follow on clinical capnography. Again, thanks for watching.